¿cómo están? Buenas noches, bienvenidos a
Hello, everyone. Good evening to the monthly session of our dear association. It's an honor to introduce the national and foreign professors. Allow me to introduce Dr. Jordan Zamora, our president. We're going to get started. May you be welcome. Hello, good evening. It's a pleasure to be with you, and most of all, to enjoy this wonderful session. We have as coordinators, I would like to thank them, particularly Dr. Rojano, Dr. Barra, and Dr. Quiroz. There will be coordinating this session. Without further ado, we will give the floor to Dr. Rojano, who will introduce our guest speaker, and then we will hear the talk. Good evening, and may all of you be welcome. Good evening. It's an honor for me to introduce our foreign professor. He's going to speak about the endoscopic sleeve gastroplasty. He is an expert in diagnostic and therapeutic endoscopy, advanced endoscopy. He's professor of GI surgery at the gastroenterology department at the medical school at Sao Paulo University. He has a PhD in research in Birmingham. He has a PhD in sciences. He is a member of the Brazilian Society of GI Endoscopy, the coordinator of the group of young endoscopists, member of the GI endoscopy group at Villanova Star Hospital and at St. Louis Hospital. It's a true honor to have Dr. Diogo T with us. We're going to listen to his talk. After that, we'll have a Q&A session so that we can take full advantage of the opportunity of having him with us.
First, I want to thank you, the Asociación Mexicana de Endoscopia Gastrointestinal. It's a pleasure to be here in this session. Unfortunately, my Spanish is not good, so I prefer to give the talk in English, but I can understand Spanish well, so during the discussion, we can talk in Spanish as well. I have no disclosures related to the endoscopic sleeve gastroplasty. As everyone knows, obesity is a pandemic nowadays, and as you can see in this graphic, the number of obesity is just increasing, as well as the number of the research. And today, obesity is one of the third most studied disease in the world. So when you talk about treatment of obesity and metabolic disease, we know the less invasive treatment is diet and lifestyle modifications. However, we know the effective is very low, most in long-term follow-up. And we also know bariatric surgery is the best approach, although it's the most invasive one. Medications are, the results of medications getting better by years, but we still have a gap between the medications and the bariatric surgery. So as we know, despite surgery is the best option, just 2% of patients who meet the criteria to be operated go to surgery. So we have a real gap here, and this gap can be filled with the endoscopic bariatric and metabolic therapies. So there are a lot of endoscopic bariatric and metabolic therapies. Some of them work in the stomach. They are usually focused on obesity, and some of them works in the small intestine. And there are more focused on metabolic disease such as diabetes. But our focus today is really gastric remodeling, so we are just talking about this during the presentation. We have 4 techniques nowadays: the ESG, the endoscopic sleeve gastroplasty, with the overstitch, the pose, endomina, and endozip. And our focus in this presentation is to talk about endoscopic sleeve gastroplasty. So when it starts, it starts many years ago with Fogel. He described it in the luminal vertical gastroplastia. The suturing device was not a full thickness device, and he did sutures on the anterior and posterior wall. His results were really good, but however, nobody could reproduce them. This is another procedure, very, very similar to what Fogel described, and using the restorative system, which also is not a full thickness suturing, and the results were not good as we intend to be. We got an excess loss of 27%. What were the problem of these techniques? First one is we didn't have the full thickness device, and the other one, they were working on the anterior wall, anterior and posterior wall. And when we study surgery techniques, we know when you go to the greater curvature, our results are going to be better than the anterior plication. And that's why the endoscopic technique evolved. As you can see here, the evolution of the endoscopic technique. So we have now the full thickness device. Suturing device. And here is the technique. Now with the ESG, we focus on the greater curvature. And that's why the results are getting better. So what is ESG? This is one of the procedures that I performed. You can see how is the sleeve-like shape after the procedure. So endoscopic sleeve gastroplasty is an incisionless, minimally invasive technique in which we remodel the greater curvature via placement of full thickness sutures. How it works? You reduce the gastric capacity and also you cause a delay in gastric emptying. So again, the mechanism of action, you promote gastric size reduction, you have a delay in gastric emptying, and with this, you have a satiety alteration. So you can eat less than you could eat before. These are the mechanisms of actions of the endoscopic sleeve gastroplasty. So what are the indications and contraindications of this procedure? In my opinion, the ideal BMI for endoscopic sleeve gastroplasty are 30 to 34 to 35. When you have patients with a BMI higher than 34, sometimes surgery can be better, especially when the patient has a BMI higher than 40. And the minimum BMI, I think 27 is quite a good BMI. Lower than that, I think balloons can work very, very well. So contraindications, different from the balloons, you can perform ESD after gastric surgery. And also when you have a hiatal hernia, you can also perform ESG. Of course, if you have a hiatal hernia larger than 5 centimeters, there is no sense to do that, but you can do. So most of the contraindications are related to active ulcers, active lesions, cancer, and coagulation disturbs. So preparation. So of course, we need to have a full labs of this patient. It's good to have an endoscopy before. You need to have a multidisciplinary team. The patient needs to go to the psychiatry, to the dietitian. It's very important. And deep venous thrombosis prophylaxis. You need to see case by case. I do like to do it. My first ESG case, I have one DVT, and that's why I always do use. Of course, you have a little bit more bleeding during the procedure, but it's very easy to manage that. Antibiotics, I think it's very important to use for 5 days. Then we can at least reduce the risk of infection. Technique, always do with the general anesthesia. CO2 insufflation is essential. You don't need to do the APC marking before the suturing. Some people like to do. I don't like to do the marking. I like to do the APC with the suturing to improve the scar after the procedure. And I think we can have better results, but not marking to perform the suturing. So antrum should never be sutured. It's very important to do not suture the antrum because we're never gonna be able to keep the sutures there. Regarding the technical aspects of the procedure, we can talk about the patterns, the need for reinforcement or not, number of sutures that you should use, if you need to do APC or not, or if we need to suture or not the fundus. So I will discuss all these technical aspects because they are very important, and you need to know that. So suture pattern, there is the triangle suture pattern, there is the N, some people do call it always Z, the rectangle, which was used in the Mary trial. So you do like a rectangle, then you start the next suture here, and then you do a rectangle again, it starts the next suture here, and they use stitch pattern. So this one is the one that I use it. Here I wrote 11, but to be honest, I do almost 20 passes with the needle. I think the more close you have, more strong it's going to be your suture. So I do like to do more than 11. And regarding the technique, which one is the best? There is no consensus. There is no studies comparing the techniques. And most of the studies show the similar weight loss. So we really need more data to see which one is the best. Regarding reinforcement, should we do reinforcement or not? Some people do like to use it, some people do not. As I usually close a lot with the U technique, I don't need to use reinforcement. But sometimes when I think the sleeve is not good enough, I do perform some reinforcement. There are two techniques: the running suturing, when your sleeve is big and you want to make it smaller, and the interrupted suture to try to reduce the pressure in the suture line. Number of sutures. This study we performed in after sleeve, so the size of the stomach were smaller, but what we saw is more suture is better than less suture. So of course, when you close more, the chance to have more success is higher. But again, there is no studies really evaluating comparing the number of sutures. APC, yes or not? So look at this video. When I use the APC, I'm going to show you the technique that I like to do. So you see a very large stomach, and after the procedure, you see I really like to close the stomach very well. So I like to make the tubular very thin. So I do use APC, but different from this technique that we published before. We did a suture and then we did some APC. Now I'm gonna come back a little bit on the slides to show you. So now I do a U, then I burn here. Then I burn here in the middle of the U, and then I do the U. Then again, I burn in the middle of the next U, and then I close, because when I close this is gonna, the APC is gonna be in the middle. So I think when it's gonna do the scare, the fibrosis is gonna be better in this situation. So that's why I like to do before the suture. So I do one 2 centimeter line of APC, like from the anterior greater curvature to posterior wall in the middle of the U. Then I do the U. Then again, I do the APC like a C, and then I do the U again. So this is the way that I like to do APC. Fundus, should we close the fundus or not? So I'm going to show you some cases that I did close. So this is the stomach, again, a very large stomach. And usually we found this. So polyps are not a contraindication. So here you see a very large stomach. And then using the APC technique and also closing the fundus, you're going to see how we can close the stomach very, very well. So see, there is no fundus anymore. I closed all the fundus. I did a lot of APC. I did reinforcement as well in this case. And you see how strong is this suturing. So when you do like this, the patient usually have more pain. So this was also my aunt, and she lost more than 25% total weight loss, but she had a lot of pain in the first 5 days. So you need to take care when you close like this. So post-procedure recommendation, hospital discharge on the same day or after 1 day. I usually like to keep the patient 1 day, especially in the private. On the public hospital, we do discharge on the same day. DVT prophylaxis, as I said before, it's case by case, but I do like to do a lot in all patients. Antibiotics, I think we should use. Medications to reduce symptoms, of course, we need to use. The patient needs to have these medications, even without symptoms, to try to not have the symptoms. Steroids for 3 days and PPI for 1 to 3 months. Usually, I just keep for 1 month. I don't like to use a lot. I do liquid diet for 4 weeks, and then 2 weeks of soft diet, and then regular diet. It's very important to keep liquid diet for at least 4 weeks, because this is the time that you're going to have the scar. So if the patient starts to eat a lot, it's going to break all the sutures, and the procedure is not going to be good. So now let's talk about the results. There is a lot of data coming. And so this is a multi-center study, a retrospective one with our center, 193 patients. We use the ASG/ASMVS threshold of more than 25% excess weight loss in 1 year, and severe adverse events less than 5%. You know what we found after 1 year? It's for obese patients, grade 1, 2, or 3. The results are really good. We had an excess weight loss at 1 year of 6%. So more than double that what they suggest. And what we saw as predictors of success was a patient, a man with age lower than 41 years old and high BMI. These were our best results. And we also analyzed adipose tissue, lean body mass, and metabolic rate. And what we found is that we do have a reduction in adipose tissue, and we don't have a reduction in lean body mass. So showing it's a good procedure, and there is no difference in metabolic rate. Adverse events, it's a very safe procedure, especially when you know how to do it well. Different from the balloons, you have more pain compared to the balloons. But after 3 days, most of the patients have no more symptoms. Nausea and vomiting are very rare, but you can have. Do a lot of medications, try to avoid this because vomiting can rupture your suture. Adverse events, we had just 2 moderate adverse events and 2 severe adverse events. At the time, it was on the beginning of our experience and also of the other centers. So these perigastric food collections were from other centers as the bleeding. And they went to surgery because we don't know how to manage it at this point. But nowadays, if you have a perigastric food collection, you can just drain it with external drainage or even endoscopic internal drainage. So this is another multi-center study, not from Brazil, from Europe and US. And again, the results are pretty good. You see a follow-up at 24 months. And the results were a total body weight loss of 18.6%, which is the median of most of these studies. Adverse events, again, was just 2%, similar adverse events, and the rate of responses were very high. Large series, we do have large series. This is a very large series from Alcatani, 1,000 patients, and again, the results are really similar between our centers. Doesn't matter which technique you are using, and there is also a lot of improvement in comorbidities such as diabetes, dyslipidemia, hypertension. So here you see the weight change, the total body weight loss. Patients have 15% total body weight loss. We do have also meta-analysis. So I showed you large series, I showed you with center studies, I showed you now meta-analysis. So 2 meta-analysis showing again total body weight loss of 16%, 16.8%. This one at 24 months, you have a 20% total body weight loss with 60% excess weight loss. So the data in the world are very, very similar with this procedure. Long-term studies, we do have long-term studies. This is a 5-year data from Richard Raya, but from 216 patients, just 38 complete the 5-year follow-up, and total body weight loss was 15.9%. But we need to understand that these results include 60% of patients received adjunctive therapy, 6% did a re-sleeve, So the procedure by itself, to be honest, I believe it works for 2 years. And after that, we need to associate other procedures or even repeat the procedure. And it's important to say this is not a problem for the procedure because, as we know, obesity is a chronic disease. So if you have weight regain after surgery, of course, you're going to have after ESG, after balloons. So you need to make sure to have a good follow-up on these patients. And of course, predictors of failure of older patients. We know all metabolic procedures, we need to have people following diet well, doing exercise, and that's why older patients get a little bit worse results. So comparing ESG versus diet, plus diet versus high-intensity diet and lifestyle modification, ESG was better. As you can see here, a higher total weight loss. We do have also a randomized control trial. This is not published yet, but you can find on this website from Paulo and the surgery. So 24 months follow-up, at 12 months you have a crossover. The results are excess weight loss of 50%, 44% in difference to the control group, 77% achieve at least 25% excess weight loss, which is considered the threshold for the ASG AMBS. Total weight loss was 16.3%, similar to other studies. And also we have a reduction in diabetes, hypertension, metabolic syndrome, and GERD, and just 2% adverse events. So the data are very similar everywhere. So this is what we should expect from an endoscopic sleeve gastroplasty. There is also results in children and adolescents. It's very important to remember we cannot do this procedure in very small kids because of the size of the device compared to the esophagus. And interesting, this study also from Alcatania, a lot of experience, and he saw a total weight loss close to 15%, which is very good result for these kids with few adverse events. Regarding comorbidities, I already showed it to you. There is an improvement in comorbidities, and this study focused exactly on that. Again, from Ishiraya, you have improvement in HbA1c. You have a reduction in waist circumference, systolic blood pressure, triglycerides, and hepatic enzymes. So it's a really good procedure. Of course, when you lose weight, you get improvement in all comorbidities related to the obesity. Now we're going to talk about safety. We already showed rate of adverse events. It's around 2.3 to 2.6 to 2.2%. Severe adverse events are very rare, just 0.8%. And of course, we need to be well trained to perform this procedure, know the complications, and know how to manage it. This is a study that we showed. So if you are starting to do ESG, I do recommend you to read it. So we are giving some tips and tricks on how to avoid adverse events. And main thing that you need to know is adequate training is essential. Always do general anesthesia. Be careful on patient position. If you're gonna, with the headaches, when you bring the tissue, if you have a lot of resistance, be careful, you are bringing another organ. So easy retraction, it's essential. Antibiotics, do use antibiotics, avoid infections. We are doing transmural suturing. And DVT prophylaxis, as I said, it's also important. We are treating obesity patients. Remember, from bariatric surgery, we can have these complications. So this is a case that we have to publish. This is a guy from Brazil, from another city. He was doing endoscopic sleeve gastroplasty, and he did a suture in the gallbladder, as you can see here. And the gallbladder, of course, this patient have a leakage from the gallbladder. So we have here bili, and this patient needs laparoscopic surgery. So be careful the position. I do like to perform the procedure on supine, semi-supine to left position. This is the better way to avoid other organs. Learning curve, efficiency on 38 cases, mastery on 55 cases. This is what I study showed. Of course, it all depends on the experience of the endoscopists with therapeutic procedures. Predictor of success. So nutritional and psychological follow-up are essential. If you just do the procedure and the patient do not do follow-up, the response for sure is going to be lower. So this is very, very important. So keep your patient on nutritional and psychological follow-up. When you compare it to balloon, as I said, on the beginning, the results are very similar, but ESG, you can keep your results for 2 years, and balloon, after 1 year, you start to have weight regain, in most cases, of course, not in all patients, and balloon associated with more nausea and emesis, and ESG with more abdominal pain. So these are the difference on the procedures, very different symptoms. ESG is much easier to in the first day compared to the balloon. So when compared to other metabolic endoscopic procedures, when you compare it to aspire assist, to pose, the results were similar between all procedures. So there is no gold standard. We need to see each patient needs and do an individual approach. When compared to bariatric surgery, I do not like to compare with surgery. They are different. There is no better or worse. You need to see your patient needs again. But this study compared with 2 techniques. And endoscopic sleeve gastroplasty, of course, you have lower weight loss than sleeve, but you do have better weight loss than lap band. And in terms of complications, ESG, you have a little bit lower hospital stay compared to surgery, of course, and a low rate of readmission and morbidity. So this study, it's just published from Alcatani, ESG versus laparoscopic sleeve gastroplasty. And what you see, it's a non-inferiority trial. So 10% total body weight loss difference was considered similar. So be careful when you interpret this data. And the results were similar, but as I said, with a non-inferiority comparing 10% total weight loss. And patients with this BMI, so BMI, low BMI. And for higher BMI, for sure, it lives better. So I don't like this kind of comparison again, but it's good to see that ESG is a very good technique. Weight regain after laparoscopic sleeve gastroplasty, you can do ESG. We published this data. The results are very similar to the primary results. ESG after ESG, so when it starts to regain weight, or you had a plateau, you can redo the procedure. See, the best time to do is when you have the plateau, you can do it and the patient is going to lose more weight. For patients who fail, when you do a re-ESG, the results are not good enough. Weight regain to perform a sleeve after ESG. So when you're going to do that, it's when your patient did not respond and they want a surgery. So be careful with the staple line to don't have the needles in between, to avoid fistulas. So it's very important to do endoscopy with the surgery and remove the suture. And the results are very good. So when you fail ESG, you can do sleeve for sure with good results. Other remodeling techniques, I do have just 4 minutes, so I'm going to go very fast on this. So we have pose 2, endozip, and endomina. So pose starts with the pose 1, going to the fundus on the antrum. The results were not good. It failed on the US trial, and then they create the new technique, pose 2, as you can see we are doing here in the bariatric endoscopy live global. And total weight loss with the pose 1 was 13%, and with pose 2 increased it to 17%. So it's a very interesting procedure. The placation, you see a very robust placation. So I do like this procedure. It's not available in South America yet, but I hope it comes soon. Weight regain after sleeve, you can also do placation. So we published this on Video GIE. It's a very interesting approach. This patient on 3-month follow-up had a quite interesting weight loss. Endomina, it's also a placation device. Interesting, endomina have a worse result, a total body weight loss at 11% at 1 year. But it's a very easy procedure. So you can use this device on the tip of your scope. You don't need any special scope. And this is the final result. So it's a quite interesting procedure and is now available, approved by the FDA. Endozip, they are still studying this device. It's a machine doing suturing for you. The first data was very good, but the company say it's still not good to use in humans for everyone. So they are still improving the device before it starts to sell. So these are the level of evidence that we have on these techniques. So we do have randomized controlled trials for almost all the procedures, except POSE2, which is ongoing on the US, and on EndoZip, which is a new device, and they are still studying the device. And of course, the problem of endoscopic sleeve gastroplasty is also the long-term follow-up. We don't have data on that. So to be honest, in my opinion, as I said before, I think 2 years is the time for ESG. After that, we need to think in another procedure if the patient is not doing well. Future devices. So this is a suturing, robotic suturing. So this we are doing a full thickness resection. The length of these scopes are not long enough to go to the stomach, but when we go to the stomach, I think this will change the role of bariatric endoscopy. Combination therapies. This is what I like to do. I like to associate now semaglutide after 6 months of the procedure. If the patient is not doing well, it's very good to do a boom on the weight loss. So associate medications are a good option. And this is a study showing that when you use liraglutide, which is a little bit worse than semaglutide, the results, you go to 24% versus 20% total weight loss. So it's very interesting to have a combined therapy. So in conclusion, I am still on time, I still have 1 minute. So consider the minimally invasive outpatient nature of endoscopic sleeve gastroplasty, the reproducibility among centers, and the favorable clinical outcomes in several studies. ESG could be regarded as safe and effective in light of the ASGE, ASMBS thresholds of more than 25% excess weight loss and less than 5% severe adverse events. Patient selection, combination therapies, and a multidisciplinary approach are keys to success. So always see your patient, talk to your patient, send them to your psychologist, your nutritionist, and also have in mind you can do combination therapy to improve the weight loss. Patient expectation must be realistic. So don't say to your patient, this is a bariatric surgery, this is not a bariatric surgery, this is an endoscopic procedure. So be realistic, say the real data for the patient, and everyone's going to be happy and you're going to avoid problems. The randomized control trials are warranted to provide a level 1 evidence to confirm satisfactory outcomes. This will establish best medical practice and contribute towards broader reimbursement. So we have now the merit trial, but we still need more data, especially on long-term follow-up. As use of endoscopic remodeling techniques grows, standardized training and accreditation process will be required to ensure patient safety and maintain good clinical outcomes. So this is a field that is growing a lot in these years. Obesity is growing, so it's very important to be aware and to know how to perform it to help our patients. So thank you very much for the invitation again. It was a real pleasure to be here. It's a quite long talk, but we could talk about all the technical details, indications, and the data. So I think it's important for people who are going to start to perform this procedure. I will take the opportunity to invite you to the Bariatric Endoscopy Live Global. So we have 20 centers doing live cases, and this is free registration on this website. So please register. We're going to be happy to have you. This year, we're going to have Dr. Martin Rojano from Mexico, who will perform live cases. So it will be awesome to have you on. Thank you so much for your attention.
Good evening, everyone. Dr. De Moura, many thanks for accepting our invitation. It's an honor to have you with us. This was an excellent talk. Now that you're here with us, we want to take advantage of having you with us virtually. We have received a series of questions from the members of our association. If we have time left, I will share a video. we get a question that I will read. What happens in post-operative patients who have undergone fundoplication? Do you think they are eligible for endoscopic sleeve gastroplasty? Yes, no, what would you suggest?
Thank you so much for the invitation. It's a pleasure to be here. So I'm listening in English, that's why I'm taking some time to respond. I need to wait the translation, but the question is very good. So this is a great question because, as you know, we cannot do intragastric balloons in patients with fundoplication. This is the most contraindication for intragastric balloons because if the patient gets vomit, they can have perforation. So that's why we don't use. So for these patients, endoscopic sleeve gastroplasty is a great option because there is no problem to do the suture in these patients. So I do have some cases and it's very easy to do and there is no problem. So for patients who want an endoscopic procedure, having a fundoplication, endoscopic sleeve gastroplasty is the best option.
Hola, buenas noches.
Good evening. Dr. De Moura, thank you very much for participating. I have another question for you. In order to determine who is the perfect patient, considering what does the patient want and what can the technique offer to the patient, the weight loss in a patient who asks you at the office, how many kilos am I going to lose in the first year? What do you tell these patients?
This is also a great question. So for me, I don't think endoscopic sleeve gastroplasty or intragastric balloon or any endoscopic therapy is eligible for all patients. I think for patients who, for example, I always give this example in talks because this is really what I trust. So when you have a patient who has his mother is obesity, like BMI of 60, a grade 3 obesity, his father has obesity, he's an obese patient from like 2 years old, and he comes to you with a BMI of higher than 50. For sure, this patient will not be a great option for endoscopic technique. So these patients I send to surgery because this is the best option nowadays for these patients. So when the patient comes to me, I always say there is no rule. You can lose more or you can lose less, or you can even don't lose anything if you don't follow. And the mean in the literature is 18% total body weight loss. To be honest, my rate is a little bit higher, but I am very strict to offer to the patient. So if I have a patient that I don't think it's going to work, I don't do the procedure. And that's why I think my rate of success is a little bit higher than the literature, because I really do, if I trust the patient that he's gonna do all the things. Another thing that I say to patients is, if you do a gastric bypass, you're gonna lose weight. Doesn't matter if you follow the diet or not in the beginning. You're gonna lose weight because you have the enteral hormones activation. But when you do an endoscopic procedure, you don't have this hormonal exchange. So what happens to these patients? They won't lose weight if they don't follow what I always say to these patients. So I always say, it all depends to you. If you follow the nutrition, if you go to the psychiatry, if you go to the gym, you walk, you do the diet, you're gonna lose weight. Otherwise, you won't lose weight. That's why I think you need to be very strict to offer endoscopic procedure for these patients.
Muchas gracias, doctor.
Thank you, doctor. Hello, Dr. De Moura. What is the association that you have found between patients who have endoscopic sleeve gastroplasty and they develop gastroesophageal reflux? Do these patients get gastroesophageal reflux? And the second patient, if a patient with a hiatal hernia can undergo an endoscopic sleeve gastroplasty?
These are also a great question. So to be honest, when these patients come to us, they have reflux because they are obese. They are like overweight or obese. So most of them has reflux. And then when you do the procedure, they lose weight and you don't have the intragastric pressure like the sleeve gastrectomy. So it's very rare to have patients with reflux. So usually the reflux get better with the endoscopic sleeve gastroplasty. Regarding hiatal hernia, what I say to the patients is you already have, and if it's larger than 2 centimeters, like a very large hiatal hernia, I think surgery is the best option for these patients, especially for the obese patients, not overweight, but the obese patients who are in gastric bypass, it's better for these patients. But if you have an overweight patient who are not eligible for gastric bypass, and you have a hiatal hernia in 2-3 centimeters, I think you can do the procedure.
Muchas gracias, doctor.
Thank you.
Doctor Diogo,
Dr. De Moura, another question is, at the large volume centers in Mexico, the endoscopic sleeve gastroplasty takes around 40 minutes. How long on average do you take to perform an endoscopic sleeve gastroplasty? And do you think that this would be sort of the standard or your model?
I also like this question a lot because it's very funny when you go to conference, people say, oh, I can do in 30 minutes, I can do in 20 minutes. We organize the course, the Bariatric Endoscopy Live Global. And when you ask people if they can do in 50 minutes, everyone, oh, I can do in 20 minutes, in 10 minutes. I don't think this is like similar to success. You know, being fast doesn't matter. If you be fast and do a bad job, I don't think it's valuable. So to be honest, I usually takes 1 hour and 20 minutes. I don't like to rush because I like to do the APC. So I do the APC and then I do the U. So I do the APC in the middle of the, so I have the U. I do the APC here before. So I did the APC and then I do the U suturing. So this is the way I do. So when I use APC, it takes more time. And I also like to close the fundus. So usually I do at least 5 sutures, 4 to 6, usually 5 sutures. And then if I need to do like if the sleeve is not too close as I like it, I do reinforcement. So I don't think you need to rush with the procedure. So it's if the patient is not very obese and like stay in the bed for 1 hour and 20 minutes, doesn't gonna make anything bad to the patient. So that's why I don't rush. But I did in a live course 2 weeks ago, and I did in 35 minutes. But to be honest, I like to do the sutures very close, the bites very close and one to the other. I think this is the best way to do. But in the course, I need to do fast. So I did one like here, and then I did like 2 centimeters to do the other. You can do in 10 minutes, but I don't think it's good to do that. I prefer to go slow and with high quality. But of course, some people can do high quality in 40 minutes. I'm not saying they are bad to do that, you know. I just say I have no rush to do it. Orlando, I think your mic is not working.
Hola, del auditorio tenemos
Hello, we have other questions from the audience. What would be the indication or when do you take the gastric fundus when you perform endoscopic sleeve gastroplasty? And what is your experience in patients who have NASH and non-alcoholic steatohepatitis, and is the ESG indicated for these patients?
So regarding the fundus, this is a very controversial. Some people, in my opinion, we need to close the fundus. So in the sleeve, they cut the fundus, and it's a very different procedure. So the mechanism of action is different. This is important to say. Some people want to compare with surgery, and it's not comparable because the sleeve, the mechanism of action is to make the gas empty faster, and the sleeve gastroplasty is different. You make it slow, so it's very different procedures. What some people say is when you keep the fundus, you're gonna have the a reservatory, and this is gonna have the food, and the patient is gonna feel satiated before. So this is what some people say they keep the fundus. For me, some people keep the fundus because they cannot close because it's a little bit more. You need more technique to do that. It's not so easy as the other suturing. I personally like to, in the beginning, I did without closing the fundus, and nowadays I'm closing the fundus, and I think the results are better. I have no data to prove that. There is just one study published in Endoscopia in 2021, comparing closing the fundus and not closing the fundus, and there was no difference. So I think we need more data to say what's the better technique, like you do APC or not, you close the funds or not. So what I showed in the presentation is what we need to know. Nobody knows. I'm just saying what I do. So I cannot prove it's better or not. What was the other question? Sorry.
Pacientes con NASH, con esteatohepatitis.
Patients with non-alcoholic steatohepatitis. What have been the results if you have had these patients with the ESG?
So for these patients, especially the ones not so obese, like patients with the BMI until 32, maximum 35, I think it's a good procedure because you know when you lose weight, it's going to get better from the NASH. All the studies show that, and I think it's a very good option. I do have some patients, but as I said, when I have a very, very high BMI patient with family history, if he's an obese patient since a kid, I don't like to do sleeve gastroplasty. I really don't trust this is gonna take a long-term result, you know. But if you have a patient, he was never obese and now he's obese, like he got married, he was working a lot, he wants some weight. For these patients, I think endoscopic therapies are the best.
Gracias, doctor.
Thank you, doctor. David, what is the profile of the physician that should be trained to perform this kind of procedures, or the profile that you would suggest?
Sorry, can you repeat the question?
¿Cuál es el perfil de la persona?
What is the profile of the physician that can be trained and learn this kind of procedures? A bariatric surgeon, endoscopist, gastroenterologists?
Yeah, I got it now. Thank you. Sorry. So, to be honest, it's very different in several countries. So in the US, most of the endoscopists are gastroenterologists. And in Brazil, I think Mexico is the same as Brazil. Most of the advanced endoscopy, the therapeutic endoscopy, they are surgeons. Like I did the fellowship in surgery and then I did endoscopy. And nowadays I just perform endoscopy. So as we have the Society of Endoscopy in Brazil, I think the endoscopists should do the procedure. But if you are a surgeon, but you have like, you are also an endoscopist, you are able to do as well. But I don't like some surgeons who are not endoscopists, like they just train it for ESG performing. In Brazil, have some people doing that. And I don't think it's an easy procedure when you learn, but you can have complications. Like people who never work who never did endoscopy, then he has esophageal perforation. What are you gonna do? So I don't think this is a procedure that anyone can do. I think you need to be an endoscopist and have the ability to solve the complications. It's very rare to have complications, but it can happen. So you need to know how to solve it. That's what I think. I know this is very controversial as well, but in Brazil, there is some surgeons, they never did endoscopy, they just learned ESG and they are doing ESG. So I think this is very dangerous.
Muchas gracias, doctor.
Hablando de complicaciones.
Speaking about complications, I would like to share some slides. I would like to share with you a very interesting case. Please share Dr. Bada's slides. We would like to share them with you, Dr. Moura, so that we can hear your opinion. I'm going to describe the case that you are about to see. This is a female patient who had undergone endoscopic sleeve gastroplasty in the United States prior to presenting to that group. The ESG had been done 2 years before. She did not lose the weight that she wanted to lose. And she would have chronic pain. And at times she had epigastric pain. Let's see if we can see the slides. This is concerning complications that have to do with fixation of the neighbor structures, like the case that you shared with us about the gallbladder. In this case, when the patient underwent a surgical sleeve, these were the findings when she underwent surgery. The slides are courtesy of Dr. Narciso León, a bariatric surgeon from Guadalajara. He operated on this patient, and I would like to know what do you think regarding the fixation to neighbor structures, like the case that you showed us with the gallbladder problem. How many turns does the assistant do? Do you change this regarding the gastric antrum, the fundus, the gastric body? I would like to know what do you think about, or the details of this technique. Let's wait for the slides to appear. Can you tell us if your assistant is an endoscopist or a technician, how many turns do you make in the anchor? These are the laparoscopic findings, Dr. Moura, when the stomach was fixed to the peritoneal wall. Next one, please. What do you think about these images where we can clearly see the anchor on the abdominal wall? What can we do to avoid?
Yeah, so this is a great thing to discuss. What happened is when you go with the helix, when you do the turning of the helix, when you bring the tissue, if it's not easy to bring the tissue, you need to stop, because for sure you're gonna have an extraluminal structure. So the thing is, when you go to the helix and it's hard to bring the tissue to the tower to do the suture, you need to stop and remove the helix, and then you go again. The major trick is always get the tissue easily. If it's not coming easily, it's because you are in another structure. So you need to take care of that.
Muy bien. En el caso que usted presentó
In the case that you shared with us of fixation to the gallbladder, how many days after was it possible to operate on the patient?
So this patient wasn't mine. It's from a friend from another city. We helped him to publish, but it was very good to learn. So the first thing is he was doing one of his first cases. So it's very important to really be prepared before he started, because you're gonna have very severe complications. The other interesting thing we learned in the case is the position of the patient. So the patient was in a position similar to ERCP. So with her abdominal with another supine position in the dorsal position, and that's why he got the gallbladder. So when you lay down with your abdomen to the bed and not a supine position, the gallbladder is gonna come to the stomach, and that's why I think he has this complication. And also, as I said, if you bring the tissue easily, you can do the plication without complications. If it's hard to bring, for sure you are taking some structure. It's very common to have the peritoneum. So have the gallbladder was a very unlucky case, but I'm sure a lot of times you got the peritoneum. So that's why I always say to my fellows, when the tissue is not coming, just stop, remove the helix and start again. It should come very easily. Otherwise, you can have problems.
Muchas gracias, doctor. Podemos quitar las
Thank you very much, doctor. Let's continue with questions by Dr. Quiroz.
In regard the timing of surgery, I think it was on the third day the patient went to surgery, because the patient was with a bili on the intercavitary. So the patient was going on sepsis, and that's why she needs surgery. And it was a very severe complication for a patient who was doing ESG because she doesn't want to do surgery. In the beginning, people thought it was like surgery with no scar. There was people were saying that, like, oh, this is a bariatric surgery without scar. And then the patient had this type of complication. So that's why I always say to patients, this is not a surgery. It's an endoscopic procedure. You're gonna reduce the size of your stomach, and you also can have complications. Because a lot of people say, oh, it's endoscopy, you don't have complications, but it's not like an endoscopy with H. pylori. It's not easy as that, you can have complications. And all the things you can take care, like antibiotics, talk to the patient, correct position, do the procedure without rush. I think this is important to avoid complication.
Muchas gracias, doctor.
Thank you, doctor. There is another question that I would like to share a video with you. This is the video showing a bleeding.
Do the procedure without rush. I think this is important to avoid complication.
Back on the air. What would be the minimum requirements that an endoscopist should meet to be able to perform this procedure safely and have the devices to control bleeding? What would you recommend?
So regarding bleeding, to be very honest, I always use APC, which may increase the risk of bleeding, but I never had a bad bleeding. So when we are doing the procedure, I think bleeding is not a complication. It's just part of the procedure. All cases you're gonna have at least a small bleeding. So when I have a bleeding, what I do, I still suture, because when you suture and you pull the suture line, you're gonna stop the bleeding. So that's what I do. I always use that. But as I said, you need to do a therapeutic endoscopy, because if you have a complication, even perforation, because sometimes when you go very strong with the helix and then you cannot close it, you need to have all the devices. So I'm never gonna do a therapeutic procedure without hemoclips, without an injector needle. So I always try to have all the procedures. I always do in hospitals. I don't do in clinic as well. I know a lot of people do it, and I don't think it's wrong to do. I think you can do it, like you don't need a hospital to do that, but I just do it in hospitals. I think it's more safe. I do with anesthesia, general anesthesia. I keep the patients in the public hospital. I can't keep the patients for 1 day, so we send them home. But in the private hospital, I always keep the patient for at least 1 night in the hospital. Not because I'm afraid of complications, but because the patient would feel like good at home. You know, for sure, you're gonna have pain, you're gonna have nausea, so you can have emesis. And I am very afraid of emesis in the first days, because you may lose your procedure and you may have bleeding. So I always like to do the procedure in the morning. I keep the patient the entire day. The patients sleep at the hospital. And then in another day, I give liquid for the patient. In the first day, I don't give anything for the patient to eat. I just keep the patient on IV fluids. And I think this is helpful to avoid nausea and emesis. And you can have the procedure, like you can have the beginning of the scar before sending this patient home. But as I said, in the literature, you can do whatever you want and send the patient home in the same day. But I just think if you have the possibility to keep the patient in the hospital, I think it's better. I don't know what is your experience in Mexico, but this is the way that I think it's the best way to do.
Sí,
Bueno.
bueno, antes déjame nomás hacer un comentario.
Allow me to make a comment and tell Dr. Moura about our experience in Mexico. I practice in Hermosillo City. We have around 400 cases reported together with Dr. David. We do outpatient surgery in these patients. They stay at the hospital for a few hours. They are discharged once they recover from the anesthesia. We are about to publish a paper reporting this case series. We haven't had any serious adverse event. 2 or 3 patients have stayed at the hospital for one night because they come from a city that is far away, but not because of a medical complication.
Doctor Moura, con base en el tiempo, le quiero hacer una pregunta más. En el tiene usted un
I have one more question for you, doctor. Have you established an endoscopic follow-up? How long after the procedure? At 6 months, 8 months? Or do you use contrast X-rays as follow-up? What do you do?
So first I'm gonna comment on Dr. Rogério. As I said, there is if you feel the patient is doing well, you can keep doing that. There is nothing wrong in do that. I just more careful to keep the patients just to make the patients have less symptoms, you know. And that's why I do it. But I know most of people in the world do it the way you do. And I know your experience, and that's why we invited you to perform live cases in the course in September. So you're gonna show how to do it. Regarding the question about follow-up, I love this question because the patients want to see how it is. And who does endoscopic gastroplastia? We know it's going to be open anyway. If you do 3 days after the procedure, it's not going to do as the same you did. You finish the procedure, you have the pictures and videos. So if the patient are losing weight, the patient are doing very well, and he wants to see, I say no, there is no. Why are you going to see? You know, because if they see it's a little bit opening, they're gonna regain weight because they think it's not working anymore. So I think that the psychological of the patient is very important. So if the patient is doing well, I don't think there is a need to see. We know how it is, you know. So why am I gonna do a procedure to lose my patient? So, but if the patient is not doing well, then I think we should do the procedure and see if it's a little bit opening. The extensibility is not good. It's like normal. It's not working the way you like it. We can do the procedure again and give the patient more options. But if the patient are doing well, I try to not do the procedure.
Muchas gracias, doctor.
Thank you very much, doctor. We are a few minutes from closing the session. I would like to take this opportunity, and I would like you to please share the slide. Dr. Moura would like to invite you. You have a few minutes so that you can invite all of us to this bariatric endoscopy meeting that you are organizing.
Thank you, Dr. Rogério. So as I said, we organized this course called Bariatric Endoscopy Live Global. This is the 3rd year of the course. Last year we had more than 2,000 registration, and this year our goal is to have more than 3,000. We have 20 centers around the world performing live cases. So each center we're gonna do one live case in September 30th. So from 7 a.m. to 7 p.m. And this year we have the pleasure to have a center from Mexico. So we're gonna have Dr. Rogério performing a case. So it's a pleasure for us. I wanna thank you for participating. And we want to invite everyone from Mexico to register in the course. Last year we have more than 100 registration from Mexico. It's a free registration. If you go to the website, you can find all the cases we performed on the other years. So we're gonna have all the cases available forever. So just go to the website and register, and we're gonna be happy to have all of you in the course. we want to invite everyone from Mexico to register in the course. Last year we have more than 100.
Muchísimas gracias, doctor. Realmente valoramos mucho.
Many thanks, doctor. We really value your time. You know how busy you are. Thank you for this wonderful talk. Thank you for sharing your experience and for answering our questions. This was a wonderful and very useful participation.
Thank you for the invitation. It was a really good discussion. As I said, I really like to discuss ESG because giving talks, everyone knows the data. I don't think just talks on you're gonna lose 18% weight loss, you have 2% of adverse events. I don't think this is good for everyone. Can see this in meta-analysis on PubMed. So I think this kind of discussion, we talk and everyone saying the experience. I think this is more important for people who want to learn the procedure and to explain the procedure. And as I always like to say, I really love to do this procedure. I love bariatric endoscopy, but I think the most important thing and the most problem of bariatric endoscopy is when we try to compare to surgery and say to the patients, we just need to say what it is because it's a very good procedure. You're going to lose around 80% weight loss. So we need to indicate the procedure with careful to don't do in everyone. And then people say it doesn't going to work. As balloon happened in Europe, in the US, they don't like it because they think, oh, we're going to regain weight after 1 year. And it's like this. If we do the correct indication, you control your patient and you can have very good results. So I hope everyone starts to perform the procedure in a good way to do it. And we can expand bariatric endoscopy around Mexico and around the world. Thank you so much for the invitation again. It was a really pleasure to be here.
Muchas gracias, doctor de Moura. Creo que sus
Once again,
conclusiones-
thank you, Dr. de Moura. Your conclusions are very important take-home messages. We need the right indication for the right patient. Congratulations for your most recent publication. It's going to become a standard for this kind of procedure. Once again, thank you, doctor. This was a very enriching talk. We've been carrying out the procedure for 1.5 years, and I take many pearls from your talk. We're going to adopt some strategies that I thought are very interesting, and we hope that in the future we will be able to collaborate with you in publications.
For sure. I really recommend do the APC between the U. This I really recommend. I'm sure this is much better than don't do it. Thank you.
Ya lo habíamos pensado, lo platicamos. Ya lo hemos platicado.
We had already thought about that, and I think it's going to be a very good idea. That's something that we already had thought about. Yes, that's going to be our next step. Dr. Jordan or Yolanda, are you there to close the session? Dr. Jordan Zamorano, Yoli Zamorano, Dr. Jordan Zamora, our president. We're going to listen to them now. Many thanks. Many thanks to all of you, Dr. Rojano, Dr. Bada, Dr. Quiroz, of course, Dr. de Moura. This was an excellent session. We have a few announcements to make for our audience. We are very happy that our first academic event will take place next week on July 14 to 16, International Endoscopy Echoes. This course has a value of 13 points for recertification by the board as part of CME credits. Please make sure you pre-register up to tomorrow, or if you prefer, you can register on site starting on July 14, starting at 7:30 a.m. We will hold a course from July 26 to 29. You can register free of charge if you are an active member of our association. If you want additional information, you can register in our webpage. We invite you to our next monthly session that will take place on August 4th with the topic Third Space Endoscopy with Maria Giovanna Porfirio Duarte at Madariaga School in Argentina, and Dr. Ana Lorena Madrigal Mendez from Mexico de Huraca Hospital in Costa Rica. We'll have a course on endoscopic management of GI stricture. It will take place on August 5 and 6 using the hybrid format. You get credits from the Gastroenterology Board, and this is part of our continuing medical education activities. You are also invited to participate in the 50th National Meeting that will take place in Mérida on September 16 to 20. Pre-registration is open for international echoes. Every Wednesday, starting at 8 p.m., we have started the new cycle of GI tricks. This is a virtual course. You can have information at our website. Register for the course on 1, 2, 3, Let's Detect with participation of national and international professors. It has CME credits as well. Endoscopy residents are invited to register as training associates so that they can enjoy all the benefits offered by the association. Write it to our email. Lastly, we invite all of our active members to register in our associates directory in our website. If you want additional information, write an email to us. These are all the announcements I wanted to make. Thank you for attending. We hope to see you next week in our next academic event. Please make sure you wear a face mask. We are at the peak of this fifth COVID wave. We're going to observe all the safety and protection measures. Dr. Jordan Zamora has the floor. Many thanks, Dr. Yoli Zamorano, our secretary. We have enjoyed an extraordinary event, and I believe that as in all of our sessions, this is always a pleasure. And we want to thank our guests. In this case, Dr. Diego de Moura from Brazil. Thank you very much for participating. And our coordinators, thanks to all of them as well. We had a very interesting discussion. And because they shared their knowledge and expertise. And we had a very cordial participation and exchange between our guest professor and our coordinators. It's extremely important to have the possibility of having exchange of experiences with people from other countries. We have people connected from Albany, Ecuador, Central and South America. Academic exchange is very important in all countries. As always, AMEG has done this. They bring the best professors to participate in our events. At this point, I would like to thank all of you for attending. We will see you next week in our International ECHOS meeting, following all the protective measures. And in September, from September 16 to 20, our conference in Mérida, Yucatán. At Viva la Vida in Cancun, we will enjoy the Caribbean and with Johns Hopkins and the Mexican Association of Gastroenterology. Welcome, everyone, and we say good evening to our associates. See you next week.